Our next speaker, who will be talking to us about post-resuscitation injury, a brain point of view, is Dr. Alfredo Sierra Unsueta. He's a doctor in intensive therapy with 34 years of experience. He is presently the head of the intensive therapy care unit at the Encalas Hospital. He has been one of the pioneers in intensive care in Mexico. He was the person who began the courses in fundamental critical care support in Mexico and in Latin America. And he's very close to the entire committee, resuscitation committee at NILCOR and the American Heart Association, as to the standards and guidelines. He's the director of the International Center of ARWAL training in resuscitation from the American Heart Association, a member of the Mexican Association of Critical Care Medicine. He belongs to the Mexican Council of Critical Care and Intensive Therapy. He's a founder of the Pan American Foundation of Critical Care and Intensive Therapy. Dr. Sierra. First of all, I want to express my thanks to the organizing committee and especially to my friend Felipe Vega. We sometimes work together with patients that have severe trauma at the Hospital Ángeles in Lomas, and I also want to express my appreciation to this magnificent organization and the entire group that has for so long been contacting me over email almost ceaselessly every 8 hours, basically, so that I could be here today. The topic that I will be discussing today, I believe, is a topic that is very important. I thought it would be advisable to give you a little bit of background on physiology, other review of physiopathology, talk about how that part of the brain, how the brain works, and resuscitation. And we're also going to look at certain treatment techniques that are presently been found to be of value, such as the use of hypothermia. We need to change the overhead. How do I change it? The slide. I'm going to talk just a few minutes about that part of the oxygen that we all feel is very important. You may remember that if you measure the difference that exists between oxygen in arterial blood and in central blood, if you measure the arteriovenous difference of oxygen to central blood, and the value is in the range of 5. But I would like for you to start paying attention to the dissociation, the oxyhemoglobin dissociation curve, which are found on the right and on the left. On the right, you can see what happens after you have provided oxygen to tissue and how both the pressure and saturation on the venous side starts to drop. There where the slope or the curve is inclined with a rapid decrease. It's not flat like in the upper part of the curve. So this happens after we have provided oxygen to the entire body, and it goes back to the right heart, the blood without the oxygen. And how does this happen? Well, this happens because we have hemoglobin, because we have volume, and because we have oxygen. It's incredible that an organ such as the heart, which weighs 300 grams, that an oxygen transporting protein that weighs less than 1 kilogram, and a blood volume for a person of about 5 liters with a normal hematocrit of about 45%, that this can handle in such an efficient manner, how it can maintain the use of and the supply and the functioning constants of all of the different organs that have differences between each other insofar as their consumption of oxygen. If we at any time stop the blood pumping through and we allow the oxygen to be consumed by cellular metabolism, we'll see that after a few minutes the oxygen has been depleted. And if initially there were 1,000 milliliters of oxygen in arterial blood, 1 minute later there are 750. 2 minutes later, half of oxygen availability, and 3 minutes later only 250. Basically nothing. When barely in 1 minute we had lost 250, we can start to see that blood saturation on the venous side is taking place at values of 70 at a pressure of 35, 36 millimeters of mercury. 2 minutes later, as you can see, we only have 500 milliliters of oxygen, and the pressure has reached a value, something that we in intensive therapy call P50. That is the necessary pressure to saturate 50% of oxyhemoglobin. But 3 minutes later, the values are so low because we have lost pressure, and oxygen is going through pressure gradients until it reaches mitochondria, where the values are very low. So yes, after the heart has stopped for whatever reason, we start to deplete oxygen very quickly, and we have very few minutes available to us so that we don't have such serious damage to the organic metabolism that would later on allow the person to survive. If 4 minutes go by, we know that the brain loses its capacity to recover. And when oxygen was discovered by Lavoisier, he was taken to the guillotine because he said that life depended on oxygen. And at that time, life only depended on God, so he ended up in the guillotine. But yes, it's quite true. Life does depend on oxygen. And such low oxygen pressure values at 25 or 27 in central venous blood clearly indicate that we have tisular hypotoxia. The heart is always consuming blood. It takes 10 milliliters or 10 volumes, or the difference between the difference there is 10 and not 5. And the other champion organ, which is in the second place, would be the brain, because the brain consumes it has an arterial venous difference of 7, but it also has a high oxygen consumption, and it has greater irrigation, greater perfusion than what the heart itself uses up, which only pumps. The brain works on many more things, many more than just pumping blood. So there are many reasons for this organ that uses up so much oxygen, it requires so much irrigation and perfusion. The brain, if it does not receive oxygen, will die, and this can be a matter of minutes. So all throughout many causes and illnesses, it's possible for there to be cerebral damage. As you can see here, I've indicated several of the reasons why the brain can suffer from hypoxia and ischemia. And then we have that other problem that when we owe oxygen to the brain and we are able to resuscitate and reestablish brain perfusion, other problems come up that are derived from the reperfusion of the brain. And this is probably where most of the problems or the damage comes up. Connected somewhat to the previous presentation of Dr. Maddox and Dr. Feliciano. How much should you not perfuse, or how much in the reperfusion do you create damage? So this definitely does happen in the brain. And there are critical items, there are critical aspects regarding reperfusion, ischemia in the brain, or ischemia reperfusion. And this is why we cannot restore function when we have these failures. If there's been an increase in calcium, edema, cellular death, necrosis. So minutes after severe ischemia, the area that is distal to the occlusion of blood flow, the area that's not receiving any blood, definitely leads to cellular death. Perhaps emergency care and intensive care units, in my opinion, their care is extremely important, but I also agree as to the timing issue. The timing is worth gold for post-resuscitation, especially when we're talking about the brain, because the brain cannot wait. The liver can be transplanted after it's been even an hour or 2 hours without any perfusion. It can still withstand hypoxia. It doesn't die, but not the brain. The brain has so many characteristics and so many difficult aspects, difficult to deal with. What we have been able to measure is that a series of kinases are freed, are liberated. Some of them have a protective effect, others have a damaging effect. And research is going back and forth, trying to see if some of these should be increased and others should be diminished. It is essential that we know this process better and better every day. What happens in the ischemic brain and what happens in the brain during reperfusion. But it's also very clear that tied to this problem are these enzymes that are freed or liberated in a disorderly fashion during ischemia and reperfusion. One of them, for example, is protein kinase C. It has been seen that its activity is increased by ischemia in the heart, in the liver, the kidneys, the brain. There are 10 different isoenzymes, and some of them, like kappa, have been associated with cerebral damage from reperfusion. It is quickly activated after ischemia, and its release is increased during reperfusion. Here we can see the role of this enzyme in cell death by reperfusion. And you will be able to see in my presentation, which will be available to you, I'm sure, on the internet, and I'm not going to spend too much time on this because it has to do with the flow chart or diagram. I recommend that you become very familiar with this. This is what has most recently been published by the European Cardiopulmonary Resuscitation Committee. And believe me, this is very similar to what has been published by the American Heart Association in its 2015 guidelines. What's happening presently insofar as hypothermia to protect and improve cerebral function or brain function, it's in, I think, a very complex stage. The guides of 2010, for 1 or 2 years, I believe, there was very interesting work that was published that demonstrated that hypothermia after resuscitation helped the brain quite a bit, and many more patients recovered. But this has been kind of been placed in doubt now, because when we measure these publications and this work has led us to see that the quality of the evidence was not at the level that was required. There was indirectness, there was indirect phenomena in the publications. When science publications do have critical and true evaluation is when we start to see the truth come out. And many of the work that has been done on hypothermia have not been able to demonstrate what was said in 2011. Here we have 3 of them, one from Bernard from 2001, and the previous ones. And you can see that in the first part of Haka's work that compares hypothermia with normal-thermia, they all compare hypothermia with normal-thermia. And these 3 studies demonstrate that induced hypothermia had greater survival rates, 52% compared to 36%. And we are very excited about this, and we are managing our patients after an episode of hypoxia ischemia, cerebral hypoxia ischemia. They don't recover, they are in a comatose state, and we are using hypothermia with good results. But what happens insofar as the new studies? 5 years of hypothermia research with more than 500 articles published on hypothermia. Thousands and thousands of induced hypothermia situations were published, and the controlled studies, random studies with a good scientific value that was reviewed extensively so that we can have a therapeutic goal as to temperature. It's not exactly hypothermia what is taking place presently. In certain patients, we do want to handle them with hypothermia, but the most important conclusion, I believe, is that avoiding this is the critical aspect for brain recovery. You can see here the curves that compare hypothermia with normothermia. A good number of cases, multi-centered, randomized, double-blind, very well documented, and they show that there was no difference between one and the other. 52 as opposed to 50 of no hypothermia, 52% with hypothermia. It's not significant. The difference is not significant. What I do believe is very important is to avoid the brain having temperatures above 36.5 degrees. So we have to constantly be very alert to the development of hyperthermia. But all of this is undergoing interesting proposals and changes currently. And I believe that we will be able to clarify all of this in the next 5 years by carrying out a thorough analysis using scientific methodology as solid as possible so that we can say with certainty this works, this doesn't work. There are many things that can come about when you lower the temperature. If hypothermia were good, we would all live in a state of hypothermia, but we live in normal-thermia. So I believe that this is where all of the organs carry out their metabolic function. They carry out the function that they were designed to carry out. They are able to develop it, carry it out optimally in normothermia, but perhaps sometimes when we're talking about resuscitation, if we have a certain temperature after resuscitation, I believe that this is can be what the future holds for us. And I think that this chart may be what the future holds. Induced hypothermia not below 33 degrees for a few hours after resuscitation, whether because of ischemia or heart attack, because of some coronary failure. All of this has been documented in different charts and forms that the American Heart Association is working on, or the European Committee on Cardiopulmonary Resuscitation, when they are discussing very clearly when hypothermia is advisable. You can see it here on the screen, and you'll have it on your computer if you download it. So the information that I brought before you today is that the brain is the most important organ, and that its life, more than any other organ, depends on perfusion and pressure and oxygen. And if we don't have a brain that has well oxygenated and with good perfusion, the brain will develop damage, and if this is extended for a period of time, it'll die. Thank you very much.
Thank you very much, Dr. Sierra. So, one of the issues has been trying to separate the body from the brain with regards to the normal thermia and the hypothermia. So, what is the goal with regards to the brain? To keep it at a lower temperature and a higher temperature to prevent any damage from the resuscitation. Currently, the hypothermia has taken the 33 degrees Celsius. We have experience with values below 33, 27, 28, but that affects important organs in an irreversible way. So the key number is 32, 33, and higher than that, the temperature should not go over 37 degrees Celsius. Otherwise, we're going to increase the mortality. And in a multiple trauma patients, where we have partly a brain damage and a 0 blood pressure, and we suspect some brain damage from perfusion, even with numbers of hyperoxygenation, what measures to take to play with the hypothermia and not to make it life-threatening on one side, and on the other side to look after the brain. That's a very hard question to answer, but gradually during the trauma, if the heart did not stop because of the volume loss and the brain was perfumed, even in a profound shock stage, and in a body that we know was born with some marvelous qualities, because knowing that we are ready from a hormone and neural standpoint for the blood to reach the brain all the time as a priority. All of that vasoconstriction and redistribution has a priority in our body, if it is okay, if it is responding properly, to take blood to the brain as the most important organ. So if the heart doesn't stop, and if we had pressure and perfusion, certainly the brain was the first organ that received blood pressure and oxygen. But if we have a cardiorespiratory attack because of a massive hemorrhage during the trauma, and the patient is resuscitated and the patient recovers and leaves the comatose stage, I think that the hypothermia should follow. So if we don't have any recovery of the conscious or awareness after the resuscitation, the patient is candidate for hypothermia to be protected. I don't know how Schumacher ended up the F1 racer. He suffered a trauma, not during a race, but skiing in the snow. But he was kept in hypothermia for a prolonged period. So I will know what actually happened eventually. That could answer your question. Thank you, doctor. Very kind of you.